Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article SWOG S0809, a Phase 2 intergroup trial of adjuvant capecitabine and gemcitabine, followed by radiotherapy, and concurrent capecitabine in extrahepatic cholangiocarcinoma and gallbladder carcinoma by Edgar Ben-Joseph et al. My name is Dr. Rebecca Mixad, and I am an attending physician and the Gastrointestinal Cancers Program Leader at Beth Israel Deaconess Medical Center in Boston, Massachusetts. My oncologic specialty is hepatobiliary malignancies. The results of SWOG S0809 are long awaited because they help build a foundation upon which we can begin to answer the question of the role of adjuvant therapy for gallbladder carcinoma and extrahepatic cholangiocarcinoma. Cancers of the biliary tract are uncommon but highly fatal malignancies that encompass several anatomical sites, of which gallbladder carcinoma and extrahepatic cholangiocarcinoma are the most common. SWOG S0809 is a prospective Phase 2 single-arm trial that enrolled patients who had undergone an R0 or R1 resection for gallbladder carcinoma or extrahepatic cholangiocarcinoma. The adjuvant regimen in SWOG S0809 consisted of capecitabine and gemcitabine for 4 cycles, followed by radiation and concurrent capecitabine. Analysis of the 79 evaluable subjects demonstrated an overall 2-year survival of 65%, which greatly exceeds the pre-specified 45% 2-year survival that was defined as promising for future development based on historical controls. Prior to SWOG S0809, the data supporting adjuvant chemotherapy, radiation, or the combination of chemotherapy and radiation after resection of biliary tract cancers were sparse at best and, at times, contradictory. For example, a 2011 nomogram based on the SEER Surveillance Epidemiology and End Results Medicare data described a benefit for chemoradiotherapy over chemotherapy alone for resected gallbladder carcinoma. For extrahepatic cholangiocarcinoma, retrospective institutional series generally support the role of adjuvant radiation with or without chemotherapy. In contrast, a 2012 meta-analysis of adjuvant therapy for all biliary tract cancers suggested that chemotherapy with or without radiation provided a survival benefit, but radiation alone did not. The only randomized trial available for inclusion in this meta-analysis compared adjuvant mitomycin C and fluorouracil to observation alone and found that gallbladder cancer was the only subgroup of multiple pancreatobiliary malignancies to demonstrate a benefit for adjuvant chemotherapy. The International European Study Group for Pancreatic Cancer, SPAC-3 trial, which was published in 2012, the same year as the meta-analysis, did not show a survival benefit for adjuvant chemotherapy, either 5-FU-based or gemcitabine, for bile duct cancer subgroup that accounted for 20% of the periampullary malignancies enrolled. These mixed results and non-definitive studies have left researchers wondering about biologic explanation for observed variations and have left clinicians to fill the void with extrapolations for more definitive adjuvant studies in pancreatic cancer. Nonetheless, many experts recommend adjuvant therapy for high-risk extrahepatic cholangiocarcinoma and gallbladder carcinoma that are generally defined as node-positive or margin-positive disease. Within the context of the limited data, the potential role for adjuvant chemotherapy is also supported by the high rate of distant recurrence, especially for patients with completely resected gallbladder cancer, while the potential role for adjuvant radiation is supported by the observation that extrahepatic cholangiocarcinoma and margin-positive gallbladder carcinoma often relapse with local regional disease. As a single-arm, non-randomized trial, interpretation of the results of SWOG S0809 is limited by the use of a historical control. It cannot definitively answer the adjuvant therapy question, nor can it separate out the relative benefit of chemotherapy, radiation, and the combination. The similarity of survival and local control results for subjects with R0 and R1 resections found in SWOG S0809 may reflect efficacy of radiation for this population with traditionally high local regional recurrence rates, or may indicate improvements in staging, surgical techniques, and supportive care compared to the historical controls, especially given the higher than expected proportion of subjects with R0 resections. The 2-year overall survival rates were estimated to be 67% and 60% for R0 and R1 resections, respectively, while 2-year disease-free survival were estimated to be 54% and 48% for R0 and R1 resections, respectively. Despite the overall good performance status of study subjects at study entry, 76% required chemotherapy dose adjustments. 15% did not receive radiation as per protocol, largely due to early progression, and a total of 14% did not complete the prescribed treatment course. In general, toxicities observed in the study were typical. 52% of subjects had grade 3 adverse events, and 11% had grade 4 adverse events. One death from a duodenal hemorrhage 5 months following completion of adjuvant therapy that may have been attributable to treatment reminds us that the benefit of adjuvant therapy may come at a cost. A notable success of SWOG S0809 is a comprehensive central review of surgical and pathology findings to confirm diagnosis and staging, as well as quality assurance of radiation therapy plans to enhance uniformity. Out of the 105 patients consented, a total of 21 were ineligible after central review, 13 by surgical review, 3 by pathologic review, and 5 for a combination of reasons. The 20% eligibility failure rate points to the surgical and diagnostic complexities of biliary tract cancers, provides a strong rationale for comprehensive central review in future trials, and may help explain variable results seen in prior studies. In addition, SWOG S0809 found that when the radiotherapy plan deviated from protocol guidelines, local regional relapse was significantly higher, 42% versus 11%. Further analysis is needed to understand how much disease heterogeneity, practice variation, and treatment tolerability contributed to this finding. The next step to confirm a benefit for adjuvant chemotherapy and chemoradiation for extrahepatic cholangiocarcinoma and gallbladder carcinoma is a large randomized controlled phase 3 trial. However, the design of such a trial needs to address several issues. First, are extrahepatic cholangiocarcinoma and gallbladder carcinoma sufficiently similar to be studied as a single entity? Emerging molecular and genetic evidence suggests that there may be crucial differences in the etiology and progression of biliary tract cancers by site of origin. For example, gallbladder carcinoma is currently thought to arise from 2 distinct pathogenic pathways. The first is a multi-stage process in the setting of cholelithiasis and chronic cholecystitis, in which p53 mutations arise early and KRAS mutations are rare. The second is characterized by frequent KRAS mutations in the setting of anomalous pancreatobiliary duct junction. In contrast, the primary risk factors for cholangiocarcinoma in the United States and Europe are primary sclerosing cholangitis, PSC, and fibropolycystic liver disease, also known as choledochal cysts. These malignancies of the bile duct epithelium tend to arise from precursor lesions, of which biliary intraepithelial neoplasia is the most common. Although there were no statistical differences in outcomes by disease site in SWOG S0809, subjects with gallbladder carcinoma consistently did worse than those with extrahepatic cholangiocarcinoma. Given the potential differences between biliary tract cancers, the second question is the feasibility of enrolling sufficient numbers of patients to conduct statistically meaningful pre-specified subgroup analysis. Although the success of SWOG S0809 suggests a national cooperative study is feasible in the United States, the relative rarity of biliary tract cancers may mean that international collaboration is needed with researchers in areas of the world with higher incidence rates, such as South America and Southeast Asia. The current Radiation Therapy Oncology Group Phase 3 randomized trial, RTOG 1112, evaluating the combination of stereotactic body radiotherapy and sorafenib for patients with high-risk liver-confined hepatocellular carcinoma, may offer some guidance regarding the potential logistical, regulatory, and drug supply barriers impacting international collaborations in cooperative group hepatobiliary cancer trials. Third, the choice of control and treatment arm is critical, especially since the chemotherapy landscape for biliary tract cancers has changed since SWOG S0809 started enrollment in 2008. Published in 2010, the randomized ABC2 trial demonstrated the superiority of gemcitabine and cisplatin over gemcitabine alone for advanced biliary tract cancers. Although there are no data for a head-to-head comparison of gemcitabine combined with capecitabine versus cisplatin in this context, ongoing European studies that compare various adjuvant chemotherapy regimens to observation alone for biliary tract cancers may provide additional reference points for control groups. Trial complexity may also be a factor if the role of radiation is evaluated in addition to comparing chemotherapy regimens. In summary, the results of SWOG S0809 are an important building block for moving forward adjuvant therapy research in extrahepatic cholangiocarcinoma and gallbladder carcinoma. Adjuvant therapy survival estimates are defined. The feasibility of an adjuvant biliary tract cancer trial in the United States is confirmed, and the use of a comprehensive central review in biliary tract cancer trials is supported. Although results of SWOG S0809 are consistent with the off-protocol practice of many, but not all experts, they are not definitive and do not change treatment guidelines. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.